This conference will now be recorded.
Good afternoon. How is everyone? And I appreciate everyone joining on screen and here in the class. My name is Diane Henry, and I am your state RAI coordinator. I work for the state health department, and I've been with the health department going on 10 years. And prior to that, I worked with the Oklahoma Foundation for Medical Quality, and we worked with the nursing homes, helping them with their quality initiatives through that program. They were the quality improvement organization contracted with CMS at that time. So for those of you here in the class, how long have you been in long-term care?
Not very long, since I started this program.
Okay, so you have a lot to learn and a lot of exciting new things to ingest and go forward. And so we're really glad to have all of the new administrators joining us, and we wish all of you good luck in your journey with the long-term care nursing homes. So today we're going to be talking about the 5-star rating system, and I'm going to cover the reason why it's important to you to know this information. You won't really have this on your test or anything, but it impacts your public reporting, all of your quality measures, and so you need to be aware of how it's calculated. We're going to go into that a little bit. And I'm going to also look at other quality initiatives that CMS has implemented and how that also correlates with the 5-star rating system. So our objectives are going to be to understand the Impact Act and the SNF Quality Reporting Program. And when I say SNF, that's of course talking about the skilled nursing facility. The Quality Reporting Program, you'll hear us refer to as SNF QRP. And then also the Value-Based Purchasing Program. And that's an incentive program that CMS has implemented to try to provide incentive payments for quality of care provided in the nursing home. And then we'll look at how that correlates with Care Compare. And then we're going to review how the 5-star rating system is calculated, and then how you also can navigate within the 5-star rating system. So CMS implemented the Nursing Home Compare, which is now called Care Compare, back in 1998. And then in 2008, 5-star rating system was added to Nursing Home Compare. And the purpose of both of these systems is to help the consumer, residents, and family members understand the quality of care being provided in each nursing home. There were previously 8 specific care websites, and then just as of last year, CMS combined all of those and now called Care Compare. So when you go to that website, you just plug in whichever setting that you're wanting to look at, such as nursing homes, and then you can pull up information and data for the nursing home. We have about 16,000 nursing homes in the nation, and all of those that are participating in Medicare or Medicaid programs submit data to Care Compare. And we will look at all of that in the upcoming slides. So I want to just give a few pointers and background on some of the CMS initiatives. And the first one we're going to talk about is the Impact Act. And that is referring to improving Medicare post-acute care transformation. And that's easier just referred to as the Impact Act. This bill was passed in 2014, and the purpose of it was so that we could achieve better outcomes, better communication between the post-acute care settings. And they standardized the assessment data between these post-acute care settings with this bill. So in other words, when we're looking at an individual's functional setting in assessment in one setting, we're comparing that same information in another setting. So easier way of looking at it is comparing apples to apples. This helps improve patient outcomes, and it also improves better care coordination upon discharge and transitions of care. And the reason CMS wanted to start looking at this was because of escalating costs. Back in 2013, it was around $59 billion just for post-acute care settings. And so the other thing, the reason they wanted to pass this bill was because they couldn't share data. One setting would be looking at the functional assessment one way, another setting would look at it another way, so it did poorly. So they needed to pass this bill to be able to standardize the data. Under the Impact Act, we now have the Skilled Quality Reporting Program, which again is SNF QRP, and then also the SNF Value-Based Purchasing Program. So we're going to take a little bit closer look at both of those. And the Skilled Nursing Quality Improvement Program is referring to incentives regarding looking at high quality of health care. We're also looking at quality of goals in the healthcare. And then they want to measure the patient outcomes. Did the patient or the resident improve in one post-acute care setting better than they did another? And what was the cost? Did it cost more for rehabilitation and inpatient rehab versus rehabilitation in a skilled nursing setting? So that's a different kinds of things that they're looking at in this reporting program. Then they also want to evaluate the patient and resident perceptions based on the care that was provided. I provided you a handout of all of your different quality measures, and they're also listed here on the screen. These are the current quality measures, and we have 13 currently. 8 of those are MDS based. And when I say MDS, that's the minimum data set. If you're not familiar with the minimum data set, that is the whole foundation of what happens in the nursing home with each resident. It's the comprehensive assessment that they're required to complete upon each resident's assessment status. So 8 of the quality measures are MDS based, and then 3 of them are claims based. Claims based, that we'll look at here in just a second, is reported on your Medicare claims. So you don't have to have any kind of additional reporting related to those measures. Then we have 2 measures related to transfer of healthcare information, and those are fairly new, and we're not currently using those 2 at the time. So we're basically focusing on 11 measures. However, just last month in April, CMS proposed a new rule, and they want to start possibly collecting data on healthcare associated infections, of course, because of COVID. That's why they're focusing on that. And then the other measure they're looking at is implementing COVID vaccination for all of the healthcare personnel. So those are 2 measures that more than likely will pass at some point, but right now they're still within the comment period, and we're looking at implementing those in the near future. These are your claims-based measures. Again, there's just 3 of them. And again, no additional reporting is required because these are calculated from the hospital claims. And it's just looking at potentially preventable 30-day post-discharge readmission, and then discharge to the community, post-acute discharge, and then, of course, the Medicare spending, how much is spent on each Medicare beneficiary. So to be in compliance with these SNF QRP requirements, you have to report at least 80% of your MDS assessments. And on those 80%, you have to have 100% of the MDS items to be able to calculate all of those quality measures that we just looked at. Those 8 quality measures, you have to have at least 100% completed on those to be able to calculate those measures. So if you look at this particular handout that I gave you, this is all of the MDS items that, and it's a table. Yeah, that one up there. And it's just all of these MDS items is what is used to calculate those MDS items that, and those quality measures that we just looked at. So you can see it's a lot of data. And our comprehensive assessment data is about 42 pages long right now. There's many different sections. So your MDS coordinator is very important to your organization. Again, they're the ones that drive reimbursement based on how they code the care plan. I mean, the MDS. It also drives the care plan. So it's very important, and it drives your survey and public reporting as well. So making sure that you're meeting this compliance, because if you don't meet it, you have a potential of getting a 2% reduction in your annual payment update at the end of the year. So again, this is why it's important for you to know this information and why I'm presenting this today, because it impacts your bottom dollar. So you want to make sure that you're meeting all this compliance. If you, for example, if you just had a $500,000 payment at the end of the year, 2% of that's $10,000. So that's a huge reduction, and one that nursing homes can't really afford to have right now. So again, to be compliant, look at your MDS data, making sure it's complete, work with your MDS coordinator. I'm going to show you some reports that administrators can pull to making sure that the MDS data is being submitted correctly. Again, one of these items, an example of what you want to look for is not having the MDS coordinator dash fill an item. And what that means is they just skip it. They just enter a dash because they don't have the information. So the reason that can happen and be like in section M, like for pressure ulcers. That's the section that we look at assessing pressure ulcers and wounds. So one of the sections in this table here I gave you is section K, and that measures weight. Weight also is correlating with measuring pressure ulcers because the resident's weight and status and all of that goes along with whether they have a potential for getting a pressure ulcer. So let's say the resident doesn't want to be weighed, and that happens a lot. We get a lot of calls from the MDS coordinator saying, I can't weigh my resident, so what do I do? Because I'm going to have to dash fill this. That's the resident's right. They have the right to refuse. We encourage the MDS coordinator or the clinician, whoever's trying to weigh them, to educate them on the need for being weighed, how it impacts their care, because if they're overweight or underweight or whatever, that needs to be adjusted, but with the dietitian. So in other words, again, if they can't be weighed, they're going to have to dash fill that item. If that occurred on more than 80% of the MDS assessments, you could possibly get that 2% reduction because you wouldn't have all the data needed to calculate those quality measures. So does that make sense? Any questions so far? Okay. Again, so we don't want to have missing data and we don't want to have a lot of dash fill data. So again, if you refer to that handout and also give that to your copy to your MDS coordinator, just to make sure they're aware of all the MDS measures that's used to calculate the quality measures, then you can make sure you're in compliance. One thing I want to caution you about, though, as a new administrator, all of your MDS data obviously should be accurate because it's all being reported to CMS. And as I said earlier, it also drives the care plan for that resident. And it impacts your quality measures, it impacts your survey. Surveyors use the MDS data before they come out to look to see what they want to assess. And so it's very important. We get reports sometimes when we're doing training with the MDS coordinators that sometimes they're being asked to adjust the responses on the MDS. And this is why I'm bringing this up, is because any clinician or any person in your nursing home that had anything to do with the MDS assessment, such as your dietary personnel, your therapist, any of those, they're required to sign at ZO 400 on the MDS. And so they're signing an attestation statement that it is accurate to the best of their knowledge and that they have completed this information. Under that statement, it also says that they are aware that they can personally be held liable or subject their organization to substantial criminal, civil, or administrative penalties for submitting false information. So I'm just encouraging you to support your MDS coordinators. Of course, you can look at it as a team and decide maybe a better response is more accurate based on the assessment data. But again, just don't submit falsified information. These are your requirements for your reporting deadlines. Again, I've given you another handout, and it is one that looks like this. This lists all of the quality measures we just covered, along with the deadlines for reporting. CMS is not going to use data from January through June of 30th of 2020 due to COVID, because they gave us a waiver. We didn't have to report this particular SNF QRP data during those timeframes. But starting in August, they were required to start reporting again. And so, I'm sorry, not, as of July 1st, they had to start reporting again. So you've got a deadline coming up of May 17th, which is just a few days. And you have to report all of your data from October 1st through December 31st of 2020. So you can see there's a lag here. There's that fourth quarter of 2020 is used to impact your fiscal year 22 payments. So make sure as we go through this, you can work with your MDS coordinator, making sure that they have submitted all the required data to meet all this deadline for May 17th. On this next slide here, you can see the final validation report. If you're not familiar with the CASPER reports, as a new administrator, I encourage you to become familiar with it and to have access yourself to the CASPER reports. And to do that, you have to submit a request to CMS to gain access. If you need help with that, you can always contact me, because that's part of our department, is we help get access to the CASPER reports. So every quarter prior to the deadline, you want to look at these reports, the final validation report. And every time the MDS coordinator submits their assessments and their batch of assessments, they should look at this final validation report to make sure it went through. Because sometimes if they're in a hurry, they may think everything was accepted and some of them end up being rejected. And so they need to look at that and fix the problem on the assessment and resubmit. The next report is the MDS data submission report. As an administrator, you probably want to look to see how many MDS assessments are being accepted and how many are being rejected. This will give you an idea of how to evaluate your MDS coordinator. If they're having a lot of rejected records, then there's a concern and there's a problem, and maybe they need to just go back to training. We provide, prior to COVID, we were providing training twice a year. It's our comprehensive training. It's a 2-day training. So we're going to start that back up now that COVID is kind of subsiding, hopefully. We're hoping to be able to get started back up with training. The other report is your missing assessment report. Again, if the MDS coordinator thinks the assessment was accepted and it wasn't, they may end up seeing a missing assessment report. Or maybe they forgot to do a discharge assessment because the resident went to the hospital and they were it was unplanned and they were in a hurry, and so they forgot to do the discharge assessment. So those are the kinds of reports to pull to make sure everything is accurate. In addition to those regular CASPER reports, you've also got your SNF QRP reports. And one is your review and correct reports. This one, again, pull it prior to the deadline. Look to see if it's what kind of accuracy you've got. And you can do the same thing with your threshold report. And we're going to look at that one here in just a minute. Your threshold report will tell you your percentage of compliance. The other report is your QRP facility level and resident level quality measure reports. All of those work together to make sure that you're in compliance. So this is what the CASPER screen looks like once you get into the system. And down at the bottom, you will see where it has SNF quality reporting program. I encourage everyone, because right up above that, it has MDS, QI, QM reports. And many times we have MDS coordinators get those two mixed up. So if you're wanting to evaluate your compliance for SNF QRP, make sure you're clicking on the right link for those particular reports. And then it will bring up all of those that are listed in the middle. Some of them we just got through covering, such as your threshold report and your resident level quality measure report. This is what your threshold report looks like. And you will see here, this one is about pressure ulcers. And then the percentage of pressure ulcers that is meeting the threshold. And you can see there on the screen, for quarter two, they had, or for quarter one, it's 56%, quarter two, 60%. This is the number of successfully submitted resident assessments. And because they have so many assessments that they have to do, it does get up into those large numbers like that. This, remember, is the 80% threshold up at the top. They have to percentage to meet the threshold. And then for quarter two, actually that's 9. Okay, this is the next report. This one is on the functional assessment. And so for quarter two here, it's got 92%. So over in the far right column, you can see number successfully submitted was 12 assessments. Number meeting the threshold was only 11. So from there, they're going to go back and they're going to pull their resident level quality measure report because it's going to show which residents triggered for that quality measure. And then they will look to see from there, on that resident's assessments, which assessment did not meet the threshold. Maybe there's nothing they can do about it. Maybe it's accurate and it's just going to end up being that way. But sometimes maybe data comes in after the fact. Maybe they were able to say get information from the hospital once the resident came back from being in the hospital. And so now they can modify that record and resubmit it so to try to help them meet the threshold. There are exceptions to the reporting requirements, and one of those exceptions we're currently in, which is the COVID public health emergency. We're just, hopefully coming out of it. But CMS gave us waivers during that time frame, like I said before, and we did not have to worry about meeting this threshold of January until June. But there's other exceptions, like we've had facilities call us and say, I've had a water line break and we've got flooding in our homes. We're going to have to evacuate. So if there's not a public health emergency, not a 1135 waiver in place, then you've got to follow these guidelines of notifying CMS within 90 days of the date that the event occurred. And you have to do it through this email. You can't mail them, you can't call them. It has to be through this email I've listed here. And tell them that you need an exception and what happened, so that they give you that exception and grace period not to be penalized on that 2% for not meeting the reporting requirements. If you have questions on SNF QRP, you can always call me. I'm glad to help anytime I can help answer any questions. But I've also given you CMS's direct SNF quality question link here. So I wanted to make sure that you have all of those resources available to you in case you have any other questions about SNF QRP. Before we move on, do you have any questions? So our next category under the Impact Act that we looked at was the Skilled Nursing Facility Value-Based Purchasing Program. This was implemented back in 2016. And we're looking at awarding nursing homes for better care, for better outcomes. That's CMS's goal, is they want to provide an incentive payment and pay nursing homes and other post-acute care settings based on quality of care and not based on, quantity. So the current measure that we're looking at is reducing hospital readmissions. They don't want a lot of readmissions within that 30-day time frame. Your payment for this, your incentive payment, is included on your Medicare claim. So again, there's no separate payments that's made. You just make sure that you look at your Medicare claims to see what is being reimbursed. And then all skilled nursing facilities are eligible for this incentive payment, including your non-critical access swing beds. So the measure that we're looking at is your 30-day all-cause readmission measure. And this means that anytime a resident is readmitted to the nursing home, I apologize, readmitted to the hospital from the nursing home, then it's going to, I don't want to say go against you, but it's going to impact this particular measure. So let's look at this a little bit more closely on this chart here. It's a little bit easier to follow. So your 30-day risk window starts when the resident was in the hospital, then they're discharged and they go to the nursing home. If they're admitted to the nursing home within that 1 day from leaving the hospital, then that's when that risk window starts. So let's say on September 1st of 2020, they were admitted to your nursing home from the hospital. So that 30-day risk window started. And then on September 10th, they had to go back to the hospital for whatever reason. That ends that risk window because they had another hospitalization. But then when they're discharged and come back to the nursing home, that starts another new 30-day risk window. There's a couple of exceptions to this. So maybe the patient had more than one post-acute care admission. So let's say they decided they wanted to go to an inpatient rehab for a few days prior to going to the nursing home. That would mean that they had 2 post-acute care admissions after the hospitalization. So that resident would not be included in this risk window for your nursing home. The other exception is that they've had greater than 1 day between the discharge. Maybe they thought they could go home and they realized, no, they can't stay home. Family can't take care of them. So they end up going back to the nursing home. So it's 2 or 3 days later. That resident, again, would be excluded from this measure. There are other diagnoses that's included. One of them is if they had cancer as a diagnosis for the prior hospitalization stay, that would be excluded. And if they did not have Medicare coverage for the whole 12 months in that risk window prior to the hospital discharge, they would be excluded. And then we always get this question, well, what if they leave against medical advice? They leave AMA. If they do, then it's excluded from this measure. So again, a look at your review and correct process. submit any questions you have to this email address here I've given you. It's SNF value-based purchasing inquiries. Make sure that all of your information is included there. Your Medicare number, which is also referred to as your CCN number, what your name, your facility's name is, and then any supporting evidence that you have if you feel like that you did not get the incentive payment that you deserved. So any questions on either one of those? Okay. We're going to move on into looking at now the it's still referred to as nursing home compare, but again, as of December of 2020, they changed it to care compare. So we're going to take a look at those. Have you accessed care compare yet?
Yes, ma'am, with my MDS coordinator.
Good, awesome. Okay, so you're familiar with what this looks like, but I'll just give a quick review of it. So when you get to the screen for care compare, you can enter your location or your zip code, maybe just your state, if that's all you want to enter. And then under provider type, you're going to choose nursing home or whatever provider type you're wanting to search for. And then you can list a name of facility if you know one that you're wanting to look at. If you don't want to, if you just want to bring up all of the nursing homes in the state, then you would just leave that blank. So this will be the next screen that pops up. And you can see here that it brings up all the list of nursing homes on the left-hand side and kind of their location on the map on the right-hand side. It will give your overall star rating. This particular nursing home got 4 stars on their overall. I want to bring your attention to the next one. I went ahead and redacted that nursing home, even though it's publicly reported. I just didn't, don't know who's in the audience, and so I didn't want to bring any embarrassment or anything. So I redacted the name, but when you see that little hand on the screen, it looks like a stop sign with a hand in it. That means that particular nursing home has been cited for abuse. And so that's publicly reported information. And their overall rating ended up being a 1. So this, again, the next screen that you click on is going to give your overall rating again. And then we've got 3 different measures that the star rating is calculated on. The first one is health inspections. That's the most important. If a facility does not have a health inspection rating, then you won't have a 5-star rating. And then, of course, the staffing and the quality of resident care. So this particular facility had a 4-star rating under their health inspections. They only got 1 star in staffing, and then they had a 5-star in their quality measures. So they did really good there. If you wanted to look further, you would click on each box where it said view rating details, and it will give you further information. Going back up to the top of the screen, you can see there the overall rating is based on the nursing home's performance of 3 sources, which is health, staffing, and quality measures. And there at the top, we're going to cover this in more detail when we talk about how the star ratings are calculated, but just to bring your attention to it now, each health inspection star rating uses the nursing home's current inspection and also the 2 prior inspections. And then also looking at 36 months of complaint inspections and 3 years of infection control. That 3 years of infection control is new. That's just been added recently. And then dropping on down, you can see the most recent inspection that this facility had was in January of 2020, and they ended up having 4 citations. And then it will also list on the screen further complaint inspections. We now are listing infection control inspections, and they had 3 just in 2020, so that was a lot for this nursing home. And they ended up having 3 citations. Well, actually, no, they had 0 citations in the 3 years for infection control. So this is just wanted to help walk you through how to navigate this information on Nursing Home Compare. Prior to publicly being reported, you will receive notice from CMS that a preview report is available. I encourage all of the administrators to look at this preview report with your MDS coordinator, looking to see what's missing, what is going to end up being your score when it is publicly reported. And I've highlighted here where it says 199. If you see a score of 199, that just means that there was too small of a number to calculate. And a rating or code of 201 means that there's missing information, so they couldn't calculate that either. If you end up having a 199 or 201, it's going to be reported as NA on Nursing Home Compare because they can't calculate it. Okay, so let's look at what do the stars mean. When this first came out, nursing homes did not like the star rating at all. They felt like they were being compared to a hotel. But because consumers were familiar with that rating, that's why CMS went ahead and went with it. So of course, the 5-star is much above average, all the way down to 1 star is below average. And again, these are what is rated: health, staffing, and quality measures. All of those are calculated separately to get a rating, and then added together to get your overall star rating. So let's look at how each one of these are calculated. We're going to first start with inspection because, again, as I said, that is the most important. So as we saw on the other screen, we used the 3 most standard health inspections along with the 36 months of complaint and infection control surveys. Anytime a surveyor has to come back out for a repeat visit to see if you've corrected any deficiencies that was on the first survey, you get added points. You don't get any for the first revisit, but you get added for the second, third, and fourth. So the reason I'm bringing this up is because all of this makes up what they call a cycle. So the 3 standard health inspections, and that's going to be like the past 3 years, and then 36 months of complaint investigations and infection control surveys, plus any repeat visits. Beginning in January of 2021 of this year, CMS resumed calculating the health inspection domain. Again, it was on hold, they were freezing the data because of COVID and not being reported to CMS. But as of March, they had to start calculating that again. So actually, yes, I said that wrong. They started looking at this domain, the health inspection domain, after surveys that occurred after March of 2020. So in the beginning, because of COVID, from January and February, they did not use that survey data. But as of March, they started using data again. So on your deficiency points, this imprint up there at the top, I have standard surveys and complaint surveys. And again, infection control surveys have been added. So if you want to make a note of that on your slide. The more points that you get on your deficiency points, of course, means the more serious it is and the more widespread throughout the facility. The fewer points is better. You don't want to have a high inspection score. We also get substandard quality of care deficiency. Those are assigned additional points. And then any kind of has non-compliance immediate jeopardy is going to be given points equal to level G. If you end up having a standard survey and a complaint survey within 15 days of each other, they're only going to calculate the deficiencies on one survey. They're not going to double dip, in other words. They'll only use the score from one of those. But your infection control surveys are a little different. If there is 2 or more infection control inspections that cite that same deficiency within a 15-day period, they're going to include all of those. If you have an infection control and a recertification or complaint survey in a 15-day window, only the infection control citations will be included in the calculation. Okay, one more handout, which is your deficiency table here. And you might want to keep this handy because we'll be referring back to it here in just a minute. But in case you're not familiar, have you seen this and are you familiar with it?
Or,
Have you seen this before and are you familiar with how to use it?
yeah, the lady before us had one similar.
When it-
Not necessarily the points, but it had like fines.
Okay, all right. So just a quick review, you reading across, like immediate jeopardy, usually you have the phrase IJ, which is immediate jeopardy. That would end up getting 50 points. And in parentheses where it says 75 points, that's what we were talking about if it's substandard quality of care. They have the option of adding additional points for substandard quality of care. Okay, so when we're talking about these waiting cycles, remember, again, earlier we talked about the 3 standard surveys, any kind of complaint survey, infection control survey, and also any revisits. That's going to be cycle 1. And when it refers to cycles, it's referring to years. So let's say cycle 1 is 2021, which is our current year. Cycle 2 would be 2020, and then cycle 3 would be 2019. So each year has a weighted factor. Our current year gets a weighted half of a point or a 0.50. The weighting factor for previous year is 1/3, and then the third year is 1/6. You will also see as a complaint, excuse me, as a complaint survey ages or an infection control survey ages and it gets older, it does not carry as much weight. And so that can change or lower your inspection score, which is a good thing. That's what we want. And it ends up changing your health inspection rating to making it better. Excuse me just a minute. We're going to be using that particular slide for calculations here in just a minute. So again, here are your repeat visits. For your first repeat visit, there are no additional points added. For your second, third, and fourth, they have additional points added all the way up to 85% of the health inspection score. And so, of course, you want to try to get your deficiencies corrected the first time so that they don't have to come back again. So to calculate your points for revisits, looking at cycle 1, an example of that would be this particular facility had 52 deficiency points that was added up based on all of those criteria that we just looked at. And then they ended up having to have 4 revisits. So because 4 is 85%, it's multiplied 52 times 0.85, and you end up getting 44.2 points added for revisits. And this is based on revisits and not the cycle that revisit occurs in. So let's look at cycle 1 again. This would be your 2021 current year. ABC Nursing Home had 7 deficiencies on their most recent survey. Then they had 3 deficiencies on their complaint survey. And then 1 revisit to ensure that they corrected all the deficiencies. So let's look back at this part here. So standard survey deficiencies, they got 2 Bs. How many points would that end up making based on this chart?
You got 2 Bs or 2, what did you say?
2 Bs as in boy,
Oh, 0.
0, right. Let's, next one. Oh, I gave you the answer. So if they had 5 Ds, what would that be?
20.
Right, 20 points. So you add the 2 Bs and the 5 Ds to get 20 for that standard survey criteria. Now we're going to look at any kind of complaint surveys they had in that recent 12 months. So they ended up having 2 Ds. So do they get any points for 2 Ds? 8 points, yes. And then they had 1 E. 8. So add those together and we get 16 points for the criteria for the complaint surveys. They didn't have to have any revisit, so they don't have any points added. So our total points, our total stopping point, you can see on the screen, we're taking the 20 for the standard surveys, the 16 for the complaint surveys, no revisit points, and then we're multiplying that times 0.15. And do you recall why it's 0.15? It's because cycle 1 gets half of a point, half of a weighted factor, I should say. So for cycle 1, we're multiplying it times half of a weighted factor, and that equals 18 points. Are you following me okay so far? All right. So now we have to look at cycle 2 because we have 3 cycles we have to go through to calculate all of this. So cycle 2 is going to be for year 2020. And this particular facility had 9 deficiencies in their first prior standard survey, 3 deficiencies on their complaint survey, and then they had to have 2 revisits. So let's look at the calculations on this. They had 3 C's, which ends up being no points based on this chart. They had 3 D's, which is 12, and so on all the way across to end up equaling 48 for their standard surveys. What did they get on their complaint surveys? They had 1 E, which is 8 points, 1 G equals 20 points, and then let's look at 1 H. Let's see why we added 40 points. Because it's in parentheses for substandard quality of care. So they were cited by the surveyor for substandard quality of care. So they got 40 points added instead of 35 on a complaint survey. So all of that equals 68 points. Their revisit points, they ended up having to have 2 revisits. And when we go back and look at our chart that I had earlier, 2 revisits means it's 50% of the inspection score. So when we add up the standard and the complaint points, 48 plus 68 equals 116. They had 2 revisits, which means that's 50%. So it ends up equaling a total of 58 points. And then you add all of those together. And because this is the second year, the second cycle, it only gets 1/3. So we get 58 points when we add and do all that calculation. Okay, our last year, our cycle 3, this is 2019. This home had 8 deficiencies on their second prior standard survey, no deficiencies on a complaint survey, and 3 revisits. So let's look at this calculation. They had 4 Ds, 2 Es, and 1 H, and that 1 H this time was not substandard quality. So they only got 35 points. But then they had 1 K. That's a lot of points. K is 125 points, which means the surveyor thought it was a pattern throughout the whole facility. J is isolated, K is a pattern throughout the facility, and then L is widespread. So all of that equals 192 points on their standard surveys. Their complaint surveys, they didn't have any. The revisit, they ended up having, what did I say? How many revisits? They had 3 revisits. And 3 revisits means they get 70% of the health inspection score based on our chart. So 70% of 192 ends up being 134.4. Adding all that together, and again, because this is cycle 3, it's only 1/6 of the health inspection score. All of that ends up being 54.4 points. After you add all of that information up and you calculate all of those points, you have to go to what I've given you the site here. It's the download section of the 5-star quality rating system. And you add all of your points up together for all of your cycles, and you end up with 130.4 points. Then you go to this table. It's called a cut point table. And it's a big table, so I can't print it and give it to you or put it in a handout. But I have given you a snippet of it here on this screen. This is what it looks like for Oklahoma. So we had 130.4 points. So we can see here on the screen, 1 star equals greater than 100.67 points, right here. If they would have been lower than 100 points, lower than equal to 100 points, and greater than 63, they would have gotten 2 stars. And you can see the date of this is April 1st, and that's the most current cut point table. But this changes, and that's why you have to keep going back and revisiting it if you're trying to figure out your own score. All of this is calculated for you, thank goodness, because this is very complicated and convoluted. But sometimes it's good to understand what they're looking at and how it's calculated, because if you look at your score and you think that there's no way I should be higher than that or something, at least you can kind of have a general idea of things to look at, see what might be wrong. Because things happen in different states, individual states, such as individual surveyors might survey differently, they may have different interpretation. CMS tries to just look at each state individually. So the ratings for the health inspection domain are based on relative performance within that state. So after all the calculation is done for all the nursing homes in the state, the top 10% with the lowest health inspection score will get the 5-star rating under their health inspection rating only. Because remember, we have staffing and quality measures rating also. Then there is a middle 70%, and they divide those up between 2 and 4 stars. And then the bottom 20% gets the 1 star. Some of the things that can impact your ratings might be a new survey. If you have a new health inspection survey, that can change. As we mentioned earlier about your complaint surveys, your infection control surveys aging out and getting older, that will change your rating. Sometimes you might decide that you want to have go before the administrative law judge for an IDR if you felt like their deficiency was not fair, or maybe they gave you a higher level of deficiency than what you felt was accurate. If so, you can go request an IDR meeting. And if you win and they change it and they lower your score, then that can impact your health inspection rating as well. So all of those would be good things to lower your score. Sometimes if you go through what they call a CHOW, which is a change in ownership with your facility, there may not be enough data collected to be able to report, like we saw earlier with the code of 199 or 201, those codes. If they don't have enough data, then they're not going to give you a rating. They'll wait until they have enough survey, because they don't want anyone being rated unfairly. When there's only 2 standard surveys, the most recent survey is going to get 60%, and then the one previous survey will get the 40% rating. Again, CMS says that the lower health inspection score indicates better performance for that nursing home. Any questions on how we calculated all of that? I know it's a lot to take you, and we don't expect you to remember and understand all of this in one setting, but I just want to expose you to the information and help you understand again why it's important for you. So our staffing domain, this looks at your total nursing hours per resident day, and your total nursing hours includes RNs, LPNs, and your nurse aides. Then there's another category just simply for RN hours per resident day. They add those 2 together to come up with your overall staffing rating. CMS, previously, nursing homes reported their staffing on a form to the surveyors. And then CMS decided that they didn't feel that that was being accurately reported. So they came up with what they call the payroll-based journal. Are you familiar with that yet? And we just refer to it as PBJ. So, it's easier to remember that way. So there's different staffing ratings within the PBJ job codes. So your RN hours include your director of nursing, and that's job code 5. Any registered nurse that has administrative duties is be job code 6. And then just simply your registered nurses are job code 7. All of this is going to be electronically in your computer system already. So you don't have to remember these job codes. But if you're just wondering, okay, no, what does that include? And we got questions about this a lot when this first came out. You know, well, what's included in my RN hours, or what's included in my overall nursing hours, that kind of thing. This is why we're breaking this down. So your LPN hours includes your LPNs with administrative duties and just simply your licensed practical nurses. Same thing with your nurse aide hours. That's just looking at all your nurse aide hours, but it also includes your medication aides and any technicians, medication technicians. PBJ data should be reported for all full-time and part-time employees. It also includes all of your contract employees, such as your physical therapist, contract physical therapist. They would be included. What's not included is hospice staff or feeding assistants or private duty nursing that maybe a family member hires. Those are not included. Just as we had reporting deadlines for your SNF QRP, we also have reporting deadlines for your PBJ. It's the end of the 45th calendar date after the last day of the fiscal quarter. Now that's just a lot of information to try to remember. So they've got this chart that you can refer to, and also I'm sure it's in your electronic database. It'll probably flag you when it's due. Starting just last month, April 2021, if the nursing home did not report data, then, or if they reported 4 or more days in a quarter with no registered nurses, then they're only going to get 1-star rating automatically without any other calculation. So make sure the CMS has to receive the data by the deadline, or you will also get a 1-star rating because they will not go back and let you submit it late. So staffing is based on nursing hours and also resident census. Your resident census comes from your MDS assessment again, and it's for a quarter. So they look at comparing that ratio and have, it's a long calculation that I'm not going to try to explain. And they use that calculation to come up with this staffing hours. So the reason they wanted the PBJ electronic information is because they can audit it back to your payroll records and make sure that it's accurate. So after all that calculation that they do, this is how another cut point table. And based on your RN hours versus your total staffing hours, you can see how you would end up being a 1-star versus a 5-star. So look at column 2. If you had your RN rating hours of 0.316 up to 0.500, and your total staffing hours, let's look at column 3. Your hours was 3.5 up to 4.0. You're going to get a 2-star. Does that make sense? Okay. So that is how they look at the staffing data, and they wanted to, again, make sure that it was accurate and transparent. So that's why they came up with this PBJ. These are some of the exceptions I was telling you about earlier. If you fail to submit your data by the deadline, again, you're only going to get a 1-star for your overall rating plus your RN staffing, and that lasts for a whole quarter. If you, again, have 4 or more days in a quarter with no RN hours reported for job codes 5 through 7, you're still only going to get a 1-star rating. There is another deadline coming up, May the 15th, which is just in 2 days. So again, just a word of caution to give you a heads up that you've got some deadlines coming up. CMS does conduct audits on the PBJ data, and if they request an audit and the nursing home fails to respond, it's going to automatically drop them down to a 1-star for that 3-month time frame. Any questions on the staffing? Okay. Getting to the last one, we had health inspection calculation, we looked at staffing calculation, and now we're going to look at the last one, quality measure calculation. Not all of the quality measures that are listed on Care Compare are included in the calculation for the star ratings. We are looking at 10 MDS-based quality measures and 5 claims-based measures. This is different than what I told you about in the SNF QRP. SNF QRP was only 8, but for quality measures for star rating, it's 10. Most nursing homes will now have an overall quality measure rating. They will have a long stay quality measure and a short stay quality measure. So these are their long stay quality measures. And your long stay is any resident that has been in the nursing home 100 days or greater. Your short stay is 100 or less than 100 days. I'm not going to review all of these. I just wanted you to be aware of what they were, but I'm not going to read them to you. And then these are their short stays. On your claims-based measures, they're looking at the number of hospitalizations per 1,000 long-stay resident days. And then also looking at emergency room department visits per 1,000 long-stay resident days. And these are your claims-based short-stay measures. So now let's get into the calculation of all of those. MDS-based is calculated if there's at least 20 resident assessments across 4 quarters. And of course, that's easy because there's so many assessments that they have to do. So that's more than likely going to always be met. Unless, of course, like I said earlier, if you had a change of ownership or something. For your claims-based measures, it's at least 20 nursing home stays over the whole year. So your long stay and short stay measures both are, again, for your 4 of the most recent quarters, and it's calculated if you have at least 20 residents, and the claims-based is 20 for the whole year. So that's the difference between the claims-based and your long stay and short stay. If there's missing or inadequate denominator size, then of course that's going to impact the data. They will calculate the data from the facility, but then they're going to use a state average to get the other sample size. For example, the facility has 12 resident assessments, so they're going to have to add 8 to that to get the 20 assessment sample size. And that really isn't something that you want because you don't know what that state average is. It may not be favorable for your facility. So hopefully you will have enough assessments that they can just calculate the measure. These quality measures are grouped into quintiles, and they're assigned different points. So all the way up to 150 points. Of course, 150 is the best performing category. And they break these down into different quality measures. I've listed some of them here. So for these quality measures listed on the screen, there's 20 to 100 points. 20 points would be the poorest performing quintile, 100 is the best performing. Again, we have another cut point table that they use to calculate the overall quality measure rating once they do all their calculations of these other points. And once all of that is summed together, then they come up with the 5-star rating. So for long stay, you can see a 5-star, you'd have to get 735 up to 1,150 to get a 5-star rating under your long stay. And then you've also got a short stay measure calculation. Then they do the overall calculation for the overall quality measure rating. Okay, well, this is ending towards the end, so hang on. We're getting there. This is a calculation of the overall star rating. Now that we've kind of have an overview of all the different health inspection, staffing, and quality measures, we put all that together to come up with our overall rating. So we always start with the health inspection rating. That's your first step. Step 2, we look at the staffing rating. If the staffing rating that we came up with after we did our quality, all of our calculations, we add a star if the staffing rating was 4 stars or 5 stars, and if it was greater than the health inspection rating. But we have to subtract a star if the staffing rating is only 1 star. So remember earlier when I said if you don't report RN hours for 4 days or more, or you don't respond to an audit, or you don't meet the deadline for reporting, you're going to get 1 star. That's going to impact your overall rating. So you definitely don't want that to happen. Step 3, on your quality measure rating, you add a star if your quality measure rating was 5, subtract if your quality measure rating was 1. And then if the health inspection rating is 1 star, it cannot be upgraded by more than 1 star based on staffing or quality measure. Are you familiar with special focus facilities?
Yeah, they just spoke about it earlier.
Okay. If they have not graduated, the maximum overall quality rating they can get is a 3 star. So we're going to look at this calculation based on what we just said. So their health inspection rating is 3, and then our staffing rating is 5. What are we supposed to do?
Yeah.
Add a star. Our quality measure is 3 stars. Are we supposed to add or subtract?
Nothing.
Right. Add a star, there's nothing that we're supposed to do on quality measures. So our overall star rating ends up being 4 stars. Okay. Example 2. Our health inspection rating is 3 stars. We're supposed to subtract a star and nothing. Overall star rating is 2 stars. Our last example, we get 2 stars on our health inspection, 3 stars on our staffing, 4 stars on our quality measures. Our overall is still 2 stars. Any questions on how that's calculated? So again, the overall rating is dependent upon the health inspection domain. If you don't have a rating for health inspection, then you can't have ratings on the others. Nothing will be reported. We reviewed a little bit about changes in ratings. This is just some other things that can occur with your facility that might end up changing your data. Changing quality measures, changing your PBJ staffing data, all of that can change what your rating is. I've just provided you some resources here on your monthly preview reports. Look in your Casper if you need help accessing your Casper or getting access to it. Be sure and contact us. I'm with the KEYS Help Desk, which stands for Quality Improvement Evaluation Service. Our email and address is there, mdshelp@health.ok.gov. Care Compare is what we've been talking about today. This is the website as well as the 5-star rating. If you're a data nerd or you have anyone that is, they can go to that data.medicare.gov. That has more data than you would ever want to know. If you end up having concerns about your star rating or questions about how it's calculated, you can always contact bettercare@cms.hhs.gov. This is, again, your links for your value-based purchasing and your quality reporting program, in case you have questions about those. And then this is my contact information. I'm also over the civil monetary penalty program. I'm hoping I never have to interact with you related to that unless it's because you're wanting to apply to use the funds. We currently, CMS currently put out a project back when COVID hit because residents could not interact with their loved ones, couldn't visit or anything. And so CMS allowed some of the CMP civil monetary penalties to be used for what they call communication technology projects. And it allowed the nursing homes to purchase iPads, iPhones, that kind of thing, to be able to communicate with their loved ones. That's still ongoing, so if your facility has not applied and they're interested, you can contact me and we can help you with that application and get it. It's very simple. There's not a proposal or anything that you have to go through for that. And then the second one is what they call the in-person visitation, and nursing homes can purchase tents, plexiglass, that kind of thing to try to help with in-person visitation, safe. Now that CMS has lifted all of those restrictions, pretty much, there's still restrictions in place because you still have to follow all of your core infection control principles. The tents would still be nice, and I think still the plexiglass is also important just to maintain that infection control. But again, those funds are still available if you're interested. And then the third type is just our regular reason. It's called an RFP, request for proposal. If you come up with something in your nursing home that you feel that the money could be used to benefit the nursing home resident, it has to benefit the residents. You can contact us and we can see if we can get that approved through CMS. One project that I'm aware of in another state, they're working on isolation and depression because of COVID. So I'm going to find out more about that and see how they're implementing that in their state. See if that's something our nursing homes are interested in. We're hoping to put out an RFP possibly September, October, but we're still kind of waiting to see how COVID's going to play out. We had to put all of the projects on hold when COVID hit because they couldn't go into the nursing homes to work with them. So they all got suspended. We're gearing back up now. Any questions on anything I've covered today? All right. Well, I appreciate you interacting and your attention and everything. I know this material is not the most interesting.
Oh, it's interesting for me. I don't have no experience, so it's all new information.
It's all, yeah, it's good to be exposed to all of it. Thank everyone online and I appreciate you joining us. I hope you all have a great rest of the day.